Hi, I'm Dr. Betty Maloney. By now, many of you have probably read or heard about the recent MMWR paper on chronic Lyme disease. It features 5 case reports of serious, and in one instance fatal, treatment-related adverse events. This is an important paper, so instead of another installment on prevention, I'd like to give you my thoughts on this paper. Every instance of patient harm is regrettable. As a physician, I'm sorry that these 5 individuals were injured by the very treatments they hoped would help them. Medicine is an inexact science. Even under ideal circumstances, things can and do go wrong. No diagnostic test is perfect. Even the best have false positive and false negative results. High-quality clinical trial evidence may document the safety and efficacy of a given medication over a large group of subjects. Yet physicians may find that it is neither safe nor effective in their individual patients. For chronic Lyme disease patients, the circumstances are far from ideal. The most commonly used diagnostic tests are based on serologic methodology, which is fraught with error. The 2-tier diagnostic strategy endorsed by the CDC is highly specific but insufficiently sensitive. This means that positive results in appropriately selected patients are true, but negative results may not be. Of the patients who remain ill after their initial treatment for Lyme disease, serology cannot distinguish between those who remain infected and those who are not. We lack high-quality clinical trial evidence to guide antibiotic choices. Chronic Lyme disease infections can produce significant tissue damage, which may be slow to heal or never heal at all. Lacking a test of cure, it's difficult to know when antibiotics should be discontinued. The adverse events highlighted in the paper, tragic as they are the sorts of things we would expect to see in patients with IV access. I would hope that the risks of IV antibiotics were discussed with each patient in the setting of shared clinical decision-making. Shared decision-making is a conversation between patients and physicians where they weigh options in light of a patient's disease burden and functional limitations. As documented in the NIH-sponsored retreatment trials, patients can have significant quality of life impairments. In those instances, the potential benefits of IV antibiotic therapy often outweigh the risks. The ILADS treatment guidelines included an in-depth discussion about shared decision-making in the context of persistent post-treatment signs and symptoms of chronic Lyme disease. It was repeatedly emphasized that physicians should closely re-evaluate patients and the diagnosis as they proceed with additional antibiotic therapy. If you haven't had a chance to read this book, How Doctors Think, I really encourage you to do so. Dr. Groopman does a great job of discussing how our minds process information as we're working through a case. He goes into great detail about the cognitive biases that can cloud our thinking. I'm concerned that the MMWR paper will trigger confirmation and attribution biases. Physicians who don't believe in chronic Lyme will think that the paper supports their position, and many will view chronic Lyme disease patients with renewed skepticism. Thus, patients and the physicians who treat them will be further marginalized. I don't know what motivated the actions of the CDC's vector-borne division. If the goal is to make chronic Lyme disease go away, I'd like to see the CDC take a more scientific approach. If chronic Lyme is the outcome of long-term infection, how do patients end up here? In some instances, it's because early aspects of the disease were not readily apparent. In others, doctors simply missed the diagnosis. Diagnostic delays can be prolonged. On average, subjects in Fallon's retreatment trial had been symptomatic for 20 months prior to being diagnosed with Lyme disease. Better physician training on tick-borne diseases, including the limitations of serology, should reduce diagnostic delays and potentially new cases of chronic Lyme disease. I wish the CDC would take the lead in improving physician training. Chronic Lyme disease may be attributed to inadequate antibiotic therapy. In some instances, the duration of treatment was simply too short. Going back to the Fallon study, 43% of the applicants to participate in the study were excluded because their prior IV antibiotic therapy had been too short. Here again, better physician training would lead to fewer cases of chronic Lyme disease. Emerging scientific evidence confirms the hypothesis held by many treating clinicians. Borrelia burgdorferi subpopulations may be tolerant of certain antibiotics and able to persist despite exposure to commonly used antibiotics for Lyme disease. It would be refreshing to see the CDC support this ongoing research rather than challenge it. As I said earlier, treatment-related adverse events in chronic Lyme disease, even predictable ones, are always regrettable. I'd like to see the CDC focus on what really matters. Patients and their physicians are not the problem. Poor diagnostic tests and the pathogen itself are. Hopefully, one day we'll see constructive CDC papers on topics that can truly reduce the numbers of patients burdened with chronic Lyme disease. Thanks for listening.